years, and I'm very pleased to introduce a topic that is very dear to my heart, and that is integration of oral health and medicine. It's interesting in that there has been growing interest in this area. As you can see on this slide, at least in this country and around the world, interest has been expressed by the Institute of Medicine report in 1995, the first ever Surgeon General's report on oral health in 2001, a recent 21st Century Guys report done by the American Dental Education Association, a roundtable report on integration of oral health and primary care by our National Academy. There's now in the works a second Surgeon General's report. The Santa Fe group has had an initiative to get Medicare dental coverage for a while. Last year, a group of senior professors and dentists issued La Cascada Declaration that suggested that dentistry and medicine should get back together again where they first started. And only this past July, the Lancet had 2 articles on oral diseases, a global public health challenge, ending the neglect of global oral health, that it's time for radical action. And one of the actions, the next slide, please, was integration. So I'll introduce this topic with a favorite story. Atul Gawande, who's a surgeon here in Boston, had a paper in an article in the New Yorker some years ago called Slow Ideas. And he talked about how the introduction of ether anesthesia in 1846 compared with the adoption of asepsis by Lister in London. Ether anesthesia was adopted like wildfire. You thought there was an internet back then. It was communicated so readily. But asepsis and sterility didn't gain widespread acceptance very quickly. The reason for that is ether was good for the doctor. It let them do things they couldn't do before. Asepsis and sterile technique really was work and meant creating new systems to create sterile environments, etc. And the same probably is true about dental implants and HIV/AIDS. Dental implants, when introduced in the early 80s, caught on like wildfire. HIV/AIDS was a detriment to the profession, with many people worried that they were seeing patients who had a death sentence attached to them who would come into their office and not tell them about that. And I think integration of oral health into general health is also a slow idea. It's been going on a long time. The next slide, please. So the Lancet recommendations that just came out and can be found in the journal itself suggested that one should improve epidemiology and oral health surveillance systems, reform of oral health care systems, education and training of the future oral health workforce would be a very important issue, tackling oral health inequities all over the world, moving upstream to maximize oral health improvement, addressing commercial determinants of oral diseases like sugar drinks, advancing research agendas, and amplifying global advocacy. I must say that with all the things, all the reports that I mentioned before and now the Lancet recommendations, my bias is a lot of words and we need more action. How to do that action is very difficult given the differences in countries around the world and even in our own country where we have some leverage doing it with different states. The next, please. This is some big picture take and think by the Health Policy Institute of the American Dental Association. This was a guest editorial called Our Dental Care System is Stuck. Marko Vijic leads this effort, and he talked about the reforms needed to drive major expansions in dental care use and meaningful sustained improvements in oral health. One, address the dental coverage gap. There is real problems in terms of access. Define and systematically measure oral health. There are really no outcome measures, and iCharms has been trying to do this, and there has been work to create some outcome measures so that value can be determined relative to cost. Tie reimbursement to outcomes, which is very important and hasn't been done, and reform the care delivery model, and that's one of my favorite areas of consideration. I do think that the history of dentistry, at least in our country, based upon 1840 creation of the Baltimore College of Dentistry, really kept dentistry separate. The physicians who started that wanted to be associated with the University of Maryland and its medical school, but that didn't happen, so they developed separately. It wasn't until 1867 when my own institution, the Harvard Dental School, came into being, the first to give the DMD degree, that there truly was association with the university and its medical school. The next, please. John Kotter is a leading business thinker, and I think this chart unfortunately shows how many years we've spent on this and how little we've progressed. So you can see that creating a climate for change, the first three blocks here, are probably where we are now, because we haven't gotten buy-in yet. We haven't empowered action. Maybe we've created a few short-term wins, but we really have a lot of work left to do. The next, please. In 2006, I wrote a paper, It's Time for a New Guy's Report. The Guy's Report of 1926 was a Carnegie Foundation report on dental education that suggested that dentistry in America stay very much aligned with medicine, but separate. And that's the key, but separate. And this has allowed, in my estimation, dental education in our country, and I think around the world, particularly in Europe, where there used to be a system of stomatology, and maybe there are one or two schools left that in fact educate dentists that way, that it's all about procedures. And I think there's less and less critical thinking going into dentistry as our patients age, as our patients have more chronic diseases. And so in 2014, with John McDonough and Christine Reedy on the right, we had this perspective piece in the New England Journal of Medicine that suggested that integrating oral and general health care would be good both in terms of education, in terms of healthcare delivery, because there was some evidence that it could lower costs and improve the health of the population. So what we're really talking about is population health, and there have been some changes that have been part of this. The next, please. This was a report that was just completed last year that was advancing dental education in the 21st century. This is fondly called the Modern Guys Report. It was led by Howard Baylett, who passed away last year, and Alan Formicola, former dean of Columbia. And it really takes place in a system of incredible change of healthcare delivery, at least in our country. So CVS, as you see on the right, is merging with Aetna. Amazon, JP Morgan, Berkshire Hathaway is working. There is something called dental service organizations that are 600 to 800 practices where the business side is managed. Values and outcomes haven't been done. There's always the Clay Christensen thoughts of disruptive innovation. Clay has been part of our senior dental leaders. And there are blue ocean strategies. So some things can really change. I realize that around the world, everybody may not know it, but the Ringling Brother and Barnum and Bailey Circus went out of business about 3 years ago, but Cirque du Soleil is thriving. And that's the kind of thinking that I think oral healthcare delivery needs. The other thing that this 21st Century Guys report suggested is there's been a 47% reduction in the amount of basic science and general health education that takes place in American dental schools. And I think that's very, very upsetting to me and a number of other people. Next, please. So the main issues for change and why integration can help: access and disparities of care around the world, medical treatment of surgical diseases, advanced science. So there's now silver-diamine for treating caries. There are other kinds of research treatments in the works for periodontal disease that has such a devastating effect on diabetes and cardiovascular disease. And although there aren't major direct evidence for this, there's a lot of associative evidence that comes from insurance studies that show that there's improvement in chronic disease management when there's good oral health and there's reduction in costs. Our population all over the world is aging, particularly in the United States, in Asia, and there's increased chronic diseases. And certainly, at least in our country, I do think that some change in the scope of oral health delivery could help relieve the primary care shortage. The next, please. So here are some options for change, at least in our country. Interprofessional education, IPE, is something that's going on, and practice. Many schools include interprofessional education with pharmacy schools, with nursing schools, but very few of them do it with their medical schools. Nurse practitioners and physician assistants have assumed a bigger role in oral health. The Smiles for Life program of the DentaQuest group has been very helpful. In fact, in our institution here, we have a primary care practice in the dental school where students see patients along with physicians and pediatricians and nurse practitioners. The other thing that impacts how dentistry is practiced in our country is practice acts. States have their own practice acts. And so in Illinois, dentists can give vaccinations. In Massachusetts, they can't. Now, how silly is that when dentists give giant needle mandibular blocks but can't give little needle vaccinations? And so practice acts really need to be addressed. Certainly changing education could add basic science and more holistic kind of learning to a dentist's repertoire. And in fact, I think the scope of dental practice could change. In Europe, there certainly was stomatology programs, and in many places, oral medicine frequently required an MD degree as well. Last but not least, I think there is a place for creating a group of champions for oral health and medicine that might require dual degree and unusual residency in either family medicine or primary care, because I do think that having the medical degree adds some clout to someone's standing, whether it be in government committees or state committees or anything like that. The next, please. So we've been working in our initiative to integrate oral health and primary care on something we call the practice of the future. That would be integrated care, that is medicine and dentistry, maybe ophthalmology, optometry, integrated financing, that is medical and dental insurance would not be separate, and which is, historically what's happened in our country, and that we would establish a true interprofessional practice. And this is something we are working on with the Harvard Medical School's Center for Primary Care. We have a lot of support for this through our initiative to integrate oral health and primary care. And we really think that these examples of integration make a difference. It's very difficult to put oral health into a medical school curriculum. We do it here for a day. There have been studies that show 2 hours at most medical schools. There's no reason that this can't be enhanced, and also no reason that it can't be promoted. And that is why I think we might need some new kinds of educational programs. When you think of it, the places where dual degree people exist are in otolaryngology, plastic and reconstructive surgery, all on the surgical side. We need to do the same thing for primary care and medical management as patients age and have more chronic diseases. When I was first in training, there were 2 anticoagulants. Now there are 11. I think that says it all. The next slide, please. So I really do think now is the time, and I look forward to hearing from our other participants, because there's some very interesting differences in Taiwan and India and other places, and I'll look forward to seeing the webinar when it's there. So thank you very much.